Good morning, good afternoon, good evening, everyone, and welcome to this fourth webinar of a five-part biweekly series on Africa's COVID-19 response. This webinar is convened by the Africa Centers for Disease Control and Prevention and FHI 360. My name is Dr. Doris Macharia. I'm FHI 360's Regional Director for East and Southern Africa. And I have the great honor of facilitating today's discussion with our two panelists who I will introduce shortly. And our webinar is titled COVID-19 Response, Protecting the Gains Made Against HIV. But before I get started, I want to encourage you all to ask your questions via the chat function in this webinar. And towards the end of the webinar, we have reserved time, promise you, for our panelists to answer your questions. So please stay tuned and keep those questions coming. Now, as we start this webinar, I would like to start with some thoughts. Last week, during the AIDS 2020 virtual conference, UNAIDS released the 2020 Global AIDS Update. And some of the key highlights were that by the end of last year, 2019, there were an estimated 38 million people living with HIV globally, with 67% on antiretroviral therapy. So this is certainly very good news. Still a lot of work needs to be done. Nonetheless, about 690,000 people have lost their lives to HIV and AIDS. And even though there were about 1.7 million newly acquired HIV infections globally last year, I think the good news also is that East and Southern Africa countries had some of the most significant decrease in new HIV infections. It is also important to note that 7 of the 14 countries that achieved their 90-90-90 target were in East and Southern Africa. These were Botswana, Eswatini, Rwanda, Namibia, Uganda, Zambia, and Zimbabwe. So I'm just really excited about that. And even more exciting is the fact that Eswatini has gone even farther ahead in the epidemic and has achieved their 95-95-95 target. So well done to them. There certainly have been very remarkable achievements. And this is no doubt because of the decades of hard work, country leadership, advocacy, successful collaboration and partnership with host governments, development partners, multilateral organizations, as well as civil society organizations. Okay, so what brings us here? We know that we have an unexpected and an unwanted disruption of COVID-19. And this has exposed a number of gaps in our HIV continuum of care that must be addressed urgently and very intentionally. Our panelists today will share with us their thoughts on how we can protect these gains in terms of our HIV programs, and we'll delve a little bit deeper into some of the approaches and strategies that are showing promise and what is working, and we'll talk about how to leverage our existing health systems, and overall, at the end of the day, improve health outcomes for people living with HIV and AIDS. So without further ado, I am extremely excited to introduce our two panelists. These are two really great colleagues I've known for years, some more recent, others more in the past, but it's such a joy to really be here to facilitate this discussion with them. And I'll ask them to make a few opening remarks. So first and foremost is Dr. Githinji Gitahi. He's with AMREF Health Africa, and he joined AMREF as the Global Chief Executive Officer in June 2015. And AMREF Health Africa is the largest African-led international organization in the continent and reaches about 11 million people each year through about 150 health-focused projects in across 35 countries. Dr. Gitahi is the co-chair of UHC 2030 Steering Committee, which is a global World Bank and World Health Organization initiative for universal health coverage. He's a member of Africa COVID-19 Response Committee and board member of the Africa Centers for Disease Control and Prevention. Welcome, Gitahi. A few remarks from you, please.
Thank you very much, Doris. And I know we'll be having a very expansive conversation, so I must thank you, FHI 360, for inviting me to speak on your webinar with Hally, and I look forward to engaging. But I think the one remark I would like to make is that all of us have been, advocating and talking and looking at what we can do to improve health systems. And we have agreed as, globally, that health is a key component of human capital together with education. And last year we had the opportunity, not only as we achieve 2030, but about 193 member countries of WHO and UN signing the first ever high-level declaration on universal health coverage, which incorporates all elements of health, including HIV and others. And those commitments were made just a few months before COVID happened. And what a shocker to us, that actually what we should have done in the past is now being forced upon us to do now. It's like, not preparing your country for war, and then you start training your soldiers when the war actually is at your border. So we'll be discussing these things, but just reflect that what we haven't invested in healthcare is now being demanded by force by COVID-19. And I think we need to reflect on these things, but I'm sure we'll be discussing more, Doris. Back to you. Thank you.
Yeah, thank you so much, Dr. Gitahi. I look forward to your discussion on how we can get into a good peace accord with this new warfare that we have. And next, our second panelist is Ms. Hally Mahler. She is the HIV Director in the Infectious Disease and Health Systems Department at FHI 360. She has worked on HIV programs globally and also in the United States for more than 30 years, focusing on various areas of prevention, care, and treatment. She's also the project director for 2 FHI 360-led flagship global HIV prevention, care, and treatment projects that are funded by USAID. The Meeting Targets and Maintaining Epidemic Control Project, also known as EPIC, as well as linkages across continuum of HIV services for key populations affected by HIV, which we also know as linkages. Welcome, Hally.
Thanks so much, Doris. I'm really happy to be here today. I think, I have watched over the last several months of how COVID-19 has been impacting our HIV programs with some horror and lots of wonder. Wonder because the infrastructure that has been built for HIV turns out to be a really fantastic infrastructure for responding to other emergency diseases. Thanks to what is in place because of HIV, we have fora for leadership. We have opportunities to really implement emergency responses within health systems, and we have a lot of creative, amazing people, public health professionals, community members on the ground able to respond. But what we've also seen is that the COVID-19 epidemic has amplified all of what's positive about our HIV programs and also all of what is still undone with our HIV programs. So we see the same people who are more at risk because of HIV, women who are in situations where they experience violence, key populations being, again, re-victimized, having additional risk because of COVID-19. But we also have seen incredible adaptations, which I know we'll talk about in the health system, that has enabled us really to retain many people on treatment, but not without, of course, continuing gaps and lots of challenges. Thanks, Doris.
Oh, thank you so much, Hally. So let's start off the conversation. We'll start off with you, Hally. You already started talking about some of the gaps and some of the gains that we've had with that COVID-19 has exploited. What has been the impact of COVID-19 on HIV programs, especially when you're looking at those 3 90s: testing, antiretroviral initiation, and viral suppression? Can you just tell us a little bit more about that?
Sure. Well, I think one of the interesting things that has happened is, as of course countries have closed down, as there have been travel restrictions, as people have become uncertain of interacting with the health system for fear of potentially coming into contact with COVID-19 patients, we've seen a lot of challenges, particularly in the first 90. The first 90 requires people to voluntarily decide that they want to get an HIV test, and also requires people to be entering the health system. And so we have seen a pretty big decrease in many programs across the world with regards to the first 90 people knowing their status. I've seen it for other programs. I know that in our own programs at FHI 360, we have seen a really big decrease. When you see that decrease, of course, it affects the whole pipeline of the cascade. There are fewer people who are testing positive, fewer people who are positive, who are getting on treatment, et cetera. And I think that we haven't really even begun to see the full impact of the decreases in testing. Although we do have some wonderful strategies. We have self-testing as a strategy. We have a lot of really creative community outreach workers who have managed to continue through this time to conduct one-on-one. And we've been able to use the online space to recruit people for testing, even to send by mail in some countries around the world self-test kits in order to do the self-testing and to be able to call a peer and discuss the results. So lots going on there. With the second 90, with people on treatment, I think we've seen a lot of efforts to protect the core of people who are on treatment. Adaptations such as home delivery or community treatment groups, bringing treatment closer to people so that they don't have to interact with the health system. But we also have some critical shortages that are potential and real because of the supply chain. And I think, supply chain is probably one of our biggest risks. I think everybody here must know that WHO put out a report in the last week that shows that 74 countries have potential shortages of ART medicines and 23 critical shortages. And we've seen that in our own programs where we literally had to negotiate with border guards to get ART across a border in order to retain people on treatment. We also, though, have seen the opportunity of multi-month dispensing really take off. There was a lot of effort prior to COVID-19, but I think COVID-19 accelerated efforts for multi-month dispensing up to 6 months. And even longer in some cases. But without the supply chain taken care of course, we can't do that. And finally, with viral load, the infrastructure, the lab infrastructure, I'll let my colleague talk more about that. It's his area of expertise. But the lab infrastructure that has been there for HIV has really supported the COVID-19 response. But as a result, in many countries, we've lost access to the labs for the routine tests. And those include tests for PrEP for clients who need to be on PrEP. That includes viral load testing and others. And so how do we rebalance the need for HIV-related testing along with this rapid scale up of COVID-19 testing, I think is something that a lot of countries are struggling with. So challenges across the cascade, opportunities across the cascade, and I think we're really now just getting a handle on how to respond and how these opportunities can really help improve our programming and paying much more attention to where we have gaps and risks. So thanks so much, Doris.
Yeah, thank you so much, Hally. And just look, you talked about health systems, and just over to Gitahi. As Hally was mentioning, the rollout of HIV programs has been successful, and also, might I add, if you can indulge me, also sustainable, primarily because of maybe close alignment to the universal health coverage principles of access, equity in access, quality of healthcare, and obviously protection of financial catastrophe. Gitahi, this is your area and your area of expertise. How can we leverage this health system that HIV has, has expanded and strengthened for COVID-19 and make sure that HIV is not left behind?
Yeah, thank you, Doris, and thank you, Hally. It's a good question, and what I can first say is that the investments that have been made vertically for HIV have actually had horizontal advantages across the health system. If you look at the health system as we know it now, if you were to just use the eye of the building blocks, you would say that, for example, in some areas where HIV investments have been significant, there have been significant gains in the health system. One of those areas is, for example, commodities and diagnostics and infrastructure. So the lab system that has been built for taking care of HIV for the last so many years has actually been the basis on which we have actually built the response for COVID-19. Originally, when we started testing, you had these stories that Africa had only 2 testing centers, for example, across the continent. And within a very, very short time, almost every single country, if you talk to Africa CDC now, has capacity to actually test for COVID-19. This capacity hasn't been built because we have bought massive laboratory equipment into these countries. We've actually gone and depended on the infrastructure that was built for HIV, and then all we've had to do is find test kits and use this equipment. So that is one example where the foundation that has been built for HIV and TB has actually come in handy for responding to this pandemic. The other area that I would say is significant is supply chain, for example. In country, if I could just call it supply chain, let me call it distribution. Now, what we've seen is that in many countries where the machines are limited to the urban belts, rural communities or rural states or county or local governments have the capacity to collect samples because people have been trained on lab and we have technologies, but transporting that sample to where the labs are is a major challenge. I'll tell you that in many countries, getting a sample, just one sample of COVID from one corner of the city to where the lab is, if you are to use, to start looking at how transportation works, will take you a week to get it there. But because of the sample distribution mechanisms that have been set up during HIV care, we have already contracts that exist with transport companies that transport samples, and therefore all we need to do is load the COVID-19 samples onto the same contract and they are transported. So this has been massively useful. The other area is human resources for health. So I'll now start to talk about where we haven't actually done very, very well. Because in some of these areas of HIV care, what has happened in many instances, in many of our countries, which is not criticism, it's just partly the reality, is that we've tended, because of the need of comprehensive care for the people living with HIV, we've tended to build service delivery as a key building block of the health system, and human resources for health kind of separate from the main health system. Now, this now says that, for example, if you enter a health facility, you may find that the primary healthcare facility, which is a health center, sits side by side with a comprehensive care clinic. And therefore, you might find that for COVID patients who are being taken care of, majority of them will not go to the CCC. They'll actually go to the health facility on the other side. And yet you may have redundant capacity on this other side, but merging the two becomes difficult because despite the fact that there are no physical barriers, there are emotional barriers, there are social barriers between these two. And I think it's time that we started to think forward about how do we start to slowly now integrate this very good capacity that's built on the HIV side with the general primary healthcare capacity. Now, there are weaknesses that are shared across now, as I conclude and get back to you, Doris. And these are weaknesses of health information systems. We know that in some countries, the health information system incorporates everything, and in some countries, the health information system for HIV/TB sits side by side with the health information system for the rest of the country. This is an area now that we need to look at integrating, and the other area is financing, finally. That actually, when you look at the challenges of financing, this is one area where the problems are shared. The problems are shared by the HIV community, and I don't know anyone who person living with HIV who also doesn't have other health needs. Not one person. The mothers who live with HIV need to deliver. They have children. They're getting children. They're breastfeeding. They have young babies who need vaccination. The people who live with HIV have needs on hypertension, diabetes. So when we talk about financing, our financing mechanisms have actually been in many of the countries that, especially the low-income countries, have been based on donor funding. It is time for us to start thinking about financing rather than funding, so that the donor funding, which is really critical for low-income countries, is incorporated into the national financing strategies. So it moves purely from being funding to being financing, because now it's incorporated, and the government start to think about how do we strategically and sustainably finance health systems, because you don't want somebody who is living with HIV to not be able to pay for ICU for COVID-19. Because ideally, even if the needs and the ARVs are paid for this person, if they cannot pay for isolation when they have COVID, they're still going to die. So we need to find a way of incorporating all the funding into a financing mechanism that's holistic, and that's what we call universal health coverage. And I think if we can look at this as an opportunity to accelerate our universal health coverage commitments, universal health coverage is an umbrella that covers everybody and their needs and brings all the resources, whether vertical or horizontal, into one basket. I think that would be my initial reflections. Back to you, Doris.
Oh, good. Thank you. And Hally, just following on from that, sort of looking at how HIV is so well integrated, but at the same time, we know, we've heard from last week AIDS meeting, and we've been knowing for some time, we are really lagging behind in terms of reaching our targets. What do we need to do? I mean, we only have, like I said, 7 out of 14 countries in East and Southern Africa. I mean, 14 countries reaching their 90 targets. I mean, that's, with all the investments that we've put in, it's quite dismal. But what are your thoughts in terms of how can we sort of catch up? How do we sort of get to ensuring that countries meet their commitments? What do we need to do as civil society organizations, development partners to get there? And maybe before you answer the question, I just want to remind participants, please post your questions. We will get to them and have Dr. Gitahi and Ms. Hally Mahler answer them. Hally, over to you.
Well, you just asked me a gigantic question, Doris. I mean, what do we need to do? We need to do more of the same and lots of different. I think more of the same investment on looking at the data, seeing where we have gaps, deploying to the places where we have gaps, deploying innovations to those places. I think we need to do a lot more on the leadership level. HIV has become sort of mundane day to day in most places. It's been a long epidemic. I can understand why, and countries have lots of other problems. I mean, Dr. Gitahi just basically explained the huge problems of the overall health system, and we have lots of gaps. HIV has been treated as special within health systems for a reason, but there's I think I have seen over the last several years a decrease in national level leadership on HIV as burnout, and not because people are not of goodwill, but because it's been around for a long time, and countries have multitude of health challenges and systematic challenges. I also think we need to double down on the populations that are still being underserved, and that is key populations including sex workers and men who have sex with men, people who inject drugs, transgender people, and people in prisons. We have to double down on adolescent girls and young women. We have a lot of successes, for example, from the PEPFAR Dreams program that need to be amplified and continued to brought to scale. Scale is a continuing challenge also. I mean, billions of dollars are being invested in HIV, but scale is still an issue. So I think more of all of those things. I also think we have just tremendous opportunities afforded to us that are underutilized around PrEP. Pre-exposure prophylaxis. We have, it's still pretty nascent in most countries. Access is still limited to few population. And so we have this incredible opportunity. We also have, there's science, there's new PrEP delivery mechanisms, injectable PrEP coming down the pike in the next year or so. And we have to be able to take advantage of the prevention side of the cascade. So really to continue to elevate the prevention side of the cascade, to continue to double down on what's working, look at our data. None of it is rocket science. There's nothing that I could say here today that's going to, suddenly change the trajectory of how we're addressing HIV programs or our successes. But I do think we have these 7 countries that have shown us with really strong political commitment. A lot of those countries, but not all, have invested their own funding, national funding, into their HIV programs in a pretty significant way. And that also shows us that that the leadership from the national level works, and really learning from those countries and what they did. A lot of them, what they have in common, well, some of them have in common that they're pretty small, and that they have been able to really do that looking at granular level of data and really finding the impact. But then we have, Uganda, which really has just had this incredible political commitment. So, but even in those countries, key populations still left behind. So we're not done, and we shouldn't rest on our laurels. I think it's the most dangerous thing we could possibly do at this point in time.
Okay, thanks, Hally. And Gitahi, I mean, when we're thinking about, Hally pointed out, HIV has been with us for some time, and we've had a lot of pitfalls, treating it as a special project, and then now, it's more or less integrated within, many programs, right? But looking at issues of young girls and women, I'm just reminded in terms of even where you are right now in Nairobi, Kenya, we have huge problem of adolescent girls getting pregnant, meaning there's unprotected sex, and already those are priority population when you look at HIV, and how are we really making the right steps going forward, and how do we ensure, looking at that particular group of young girls and women in terms of ensuring that we can get services to them, whether it be HIV testing services, SRH services that are all integrated. How can we do this better within the COVID lens, especially for that kind of population, and with the kind of crises that are happening right now in a country like Kenya with this sort of spike in adolescent pregnancies because of lockdowns?
There you are. I think we are faced with several problems that reflect your question. The question number 1 is governance. When I talk about governance, allow me to include community participation and community empowerment under this model of governance. And if you look at the challenge you're raising, is actually a challenge of agency, that actually within our context, we have refused to give girls agency, and we have actually decided we need to decide for them. And therefore, the conversation that I've had in many African countries, including Kenya, including conversations that came up during the ICPD 25, which we held here in Kenya, was that, I remember one president, which I don't have to name here, standing on the podium and saying, I, as a parent, the president is 70-something years, maybe using that you may narrow down to the African presidents, and said, I have young granddaughters, and I am the consultant for them for their bodies. I am the consultant, so they need to consult me. Even anyone who needs to do something and who is running business needs a consultant, and I want to be the consultant to their bodies. Now, this is the concept of top-down governance, where we don't want actually the young girls to have their own agency. So we have debates around, for example, sex education in schools, comprehensive sexuality education, which government have insisted and refused to do because they keep saying the parents must take care of their children. Actually, we had a minister of education recently publicly say the challenge of teenage pregnancy in Kenya, even during COVID, is the failure of parenting. It's a failure of parenting because the parents are the ones who should be taking care of their daughter. They should be telling them what to do, and they have failed to do so. At the same time, we have failed to allow comprehensive sexuality education in the schools. We've failed to allow the voices of the girls on the table when we are having those conversations. When we are discussing whether to close or open schools, we don't have the girls in that room discussing whether it should be opened or closed. Because as I say, you know, in many of our schools, other than just going to teach the girls, you know, the schools are also distribution points, for example, for sanitary hygiene. Now, when they're discussing opening or closing, there's no conversation around, since the schools are the one holding the sanitary pads for the girls which are provided by the government for free, are we going to also change the supply chain and make sure they go to the community because we are closing schools for a year? And I don't expect a 63-year-old man and a 55 or 70-year-old woman sitting in a room thinking about that unless the girl is in the room. So this is one big area of governance that we have actually failed to do. The next issue is the neglect of public health functions within a UHC. When we talk about universal health coverage, we've talked more around care, primary care, secondary care, and tertiary care. And we've tended to see it through hospital facilities, health facilities, and the financing of those. This is why even when we talk about, you asked earlier about health financing. When we talk about health financing, even when you look at the measures, we look at per capita expenditure. We look at per capita expenditure based on the allocation to the Ministry of Health. But health promotion, health prevention, all those things are not catered for. And this has been a significant exclusion in the overall UHC conversation. So we're saying that public health, health promotion, health prevention, including for HIV, need to be included as a common good and budgeted for as a common good, so that governments actually own that process all the way from, you know, through the school system. It's a multi-stakeholder or multi-sector action for health promotion, health prevention, and then resolve the governance issue and participation of the people themselves. I think probably that's the shortest response I can give you on your question.
Okay, okay. And Hally, you know, I mean, what we've seen a lot with COVID is there have been definitely a number of service delivery barriers for the people living with HIV, right? Closure of health facilities, a shortage of healthcare staff, maybe because they're sick or unfortunately redeployed to something else, and reluctance of PLHIVs, people living with HIV, attending clinics due to, you know, fear of exposure, right? So from a policy point of view, and thinking about we need to reach those targets, we need to reach our 90-90 targets, you know, how do we, as civil society organization, development partners, overcome those real or perceived barriers experienced by PLHIVs during these COVID times? Because it is affecting and having an impact on our HIV programs.
I think Gitahi just hit on it actually
Yes.
extremely well. It's the community. The response needs to be come and led from the community as well. I mean, it's a lesson we seem to keep learning. I mean, I've been in this business 30-something years. I'm sure you've been the same. Every 2 years, somebody has a revelation that, oh, we should be consulting the community, or the community should be in the lead on this thing. And yet here we are. Still, of course, you know, small improvements all the time, but really no. And actually, the services led by the community are some of the most impacted services by COVID-19. We did a survey of FHI 360's HIV programs. So we looked at 51 projects in 33 countries. And the most impacted service are community-based health services that are run by key population-led or key population competent and NGOs in the field, because they are not considered in the national response in the way that they should be, even though they are primary responders for key populations and other at-risk populations. So you know, I think, you know, the community has to be in the lead if we're going to be able to overcome these challenges. They have to be at the table. We have to not forget them when we're looking at the services that are available to people and how people access services. I mean, so much of what happens in African context happens in the informal sector, and access to medicines happens in the informal sector. And some of the most successful ART programs that we have are all about programs that bring ART closer to the people. I think it's critically important that some of the adaptations that we've made during this COVID time, more MMD, more delivery of ART being client-centered, client-centered availability of self-test kits, all of that, we have to find ways to retain it. I see already some countries pulling back as they're opening back up, saying, okay, well, we don't need that anymore. But actually, that is the pathway to increase success for our HIV programs with or without COVID. COVID has proven basically proof of concept that it works. So I don't know how. I would be open to my colleague here, speaking about like how can we convince policymakers to not shut back down to sort of the everyday model, but to have used COVID-19 as a catalyst moment for our HIV programs to really change the way that we're doing business. And to reinvest in the community. It's only the community wearing masks that is gonna stop COVID-19 spread. It's only the community response, staying home if you're sick and you have symptoms, or seeking care if you need it. Those are the things that are gonna end COVID-19, and they're the things that are gonna end the HIV epidemic as well.
Yeah. Thanks, Hally. Dr. Gitahi, you want to say something? Yeah.
Yeah, I think just to add to what Hally has said, is the only way, and I was thinking about this recently, that and I've seen somebody ask about the role of private pharmacies, for example, this. It's something that I like to call trust capital. Mm-hmm. That a lot of times we talk about fiscal capital or financial capital. Where is the money? We need the money to do the following. We need the money to do this and that. And actually, when COVID comes, you find that the money is pouring. We're spending trillions of dollars, actually, trillions, which we could have spent to build a proper system many years ago, but we did not. So let's not go back to the past. But we are spending trillions of money, and we're still getting poor results. And the reason we are getting poor results is not because of absence of financial capital. It's because of absence of trust capital. And trust capital is free. Trust capital is built on mutuality, where people, I expect you to do good and me to do good. And if we could focus moving forward on building trust capital, we would do a better job between public and private partnerships. Because even now, if I look at South Africa, where you are, Doris, almost 53% of all the tests for COVID-19 are done in the private sector. Only 47% are done by public sector. When you look at many other countries, 100% or maybe 95% are government, because the government doesn't trust the private sector will do the right thing with the COVID tests. They don't trust they will actually follow the protocol. Now, this mistrust is also played when we come to dealing with, for example, supply chain, commodity supply, service delivery. Does the government, even as we are building universal health coverage and we are giving people social health insurance, are we going to trust that the private sector can also see our citizens and be able to give them good, optimal outcomes that we pay for as government through publicly financed universal health coverage? So as we move forward, if we don't focus on building trust capital between government and NGOs and civil society, trust capital between government and private sector, trust capital in the international solidarity arena. We've seen what's happening with WHO and the US, for example. How do we build trust capital as actually free and yet more important than financial capital? I think that's the bit I would like to add, that if we are going to have full community participation, and we are going to have community participation that is institutionalized, not left to the whims of the funders, then we must build trust capital. Because the reason government don't institutionalize civil society engagement is because of trust. Because they're not sure whether they can trust civil society. They're not sure whether civil society next year will campaign against them when they are running the elections. So if we can focus this world on building trust capital, I think it will be a much better world globally, nationally, and also locally.
Wow, thanks Gitahi, and thanks Hally for that sort of really good, I think, response to that question. But perhaps before we start looking at some of the questions that have been posed, recently, early in June, as you've been following some of the COVID-19 research and studies coming up here in the Western Cape in South Africa, reported that people with HIV have a 2 to 3-fold increase of dying with COVID-19. And this is real. And some of the questions I know I've been getting is like, okay, what do I need to do? Can we unpack this further? What does this actually practically mean for a PLHIV, person living with HIV? What must they do? How do they reduce their risk? Hally, maybe we start with you and then Gitahi.
I mean, it shows how critically important it is to know your status and to be virally suppressed. People who are virally suppressed, generally, most of the research is showing have the same COVID results as somebody who does not have HIV, who's otherwise healthy, or with the same level of comorbidities. So I mean, I think what it does show is just how risky it is to not know your status and how risky it is to be virally unsuppressed. It's a strong case for an undetectable viral load, and a strong reason to remain that way beyond the usual U equals U messaging. Maybe it's U equals U, like, you're undetectable means you survive. And I think it's just incredibly important to reinforce that as much as possible. It will help us to get to the end of HIV, and it will help people stay healthier while we continue to look for therapeutics, vaccines, and effective treatments for COVID-19. It's not, of course, any kind of guarantee, but it makes a huge difference because the comorbidities that you have make such a huge difference in whether or not you survive your bout with COVID-19.
Thanks. Gitahi?
If I add anything to what Hally has said, I will be taking away. So I'll not add anything. I would like that message to stay.
Wow. Okay, that's good. Yeah, and I think just to add on to what Hally was also saying is, of course, when you're HIV positive and you're taking your ARVs, you're likely to be well, and some of these comorbidities do creep up. As with other people who are not necessarily living with HIV. So it is also to remember that you have to know your status, you have to get tested, take your medication. And we've also talked about, the fact that, the service delivery maybe is not as efficient as it was before COVID times, but certainly continue taking your medication. I would like to take one of the questions that we have here that was posed. It's from Dorothy Okua in Nigeria. She's asking, what role do you see for private community pharmacies that have remained open during the lockdown? What is their role with regards to HIV services and provision of ART and likely other medication? Maybe you want to take that question, Hally?
Sure. I mean, decentralized drug distribution for ART is a foundational opportunity for our HIV programs, and private pharmacies are an ideal partner. I think Gitahi talked about how that trust, right? And making even public sector ART available through private sector pharmacies is a strategy that has been very successful in several places, including in certain states in Nigeria, I happen to know. And I think that that more we can do to build the opportunity of private pharmacies to help respond to HIV. It brings drugs closer to where the people are, provides them the opportunity to receive those services in a less crowded, convenient to them space. And there's a lot of different models out there with regards to how to work with private sector pharmacies on ART distribution. different financing models associated with that. And there's a lot to continue to explore. So I know there are multiple countries actually that are currently now, even through the EPIC project, we have 8 countries looking at decentralized drug distribution through the private sector pharmacies as a primary opportunity. And I think that we're going to see more and more growth in that area than we have already. I think the other thing is on the PrEP side. There's a lot of discussion about whether or not, for example, if we have an injectable PrEP a year or 2 from now, would that be able to be something that can be delivered from private sector pharmacy? And so national regulatory bodies provide opportunities, but also really limit the opportunities that are there in order to increase access to ART and PrEP and other therapeutics in the community. And so again, building more trust, looking at strategies that we could use to build the capacity of sector pharmacies to be able to deliver those services, I think are extremely important. And with COVID-19, more than ever, because it does keep people who are not sick out of health facilities where they don't necessarily need to be.
Yeah, thank you, Hally. And Gitahi, there is a question from Ashini Fernando. How do you manage the monitoring of viral loads during the pandemic when there's increasing demand for the same diagnostic platform, like with obviously COVID PCR testing? What are your thoughts?
Yeah, I would only share my thoughts, and would like to hear also what Hally says. My own experience, because I'm more of a health system person rather than HIV programming, is that what we've seen is that the capacity that we have across Africa for HIV testing is actually adequate, and in many areas actually excessive. And what we've seen is that in many areas, the government, if you have a government-led but participatory process, the people where these equipment are can actually plan and say, we are going to provide only 50% capacity here for COVID, and the other 50% must remain this way. This is the importance of integration. What you don't want to do is, if you have absence of integration, and then you have some areas that are probably allocating resources properly, but others are not, then you end up with kind of imbalances and increased inequalities or exacerbated inequalities. So I actually think that the capacity is adequate to actually do both, but beyond that is to bring in the private sector. As I said earlier, that the capacity that we have now for HIV, especially under the programming that we do, is largely in the public sector. Now the private sector, if it's brought in as a partner into the COVID testing, as has happened in South Africa and other places, also releases pressure on some of this equipment that is being used for viral loads, within the public sector. I am sure that Hally has a much better answer than I do, but that's my view.
Hally, do you want
what
to
I love about this is you have the systemic. Oh, sorry, you have the systemic response, and I have so. We are seeing a lot of disruptions for viral load right now. No kidding. There are a lot of people not getting their results. Countries that were already very fragile for viral load, like South Sudan, for example, COVID-19 COVID-19 amplifies everything. So if you're a place that's been struggling with viral load, of which we have a lot of countries that still struggle with viral load, COVID-19 has just amplified that, put more pressure on the system. So, I think there's, I'm not an expert on the lab side of things. I wouldn't pretend to be. There is a lot that people are doing to try to expand lab capacity right now. But it's true that the machines that we have, the PCR machines, the gene expert machines, what it is that we have currently in the lab, they are being used for COVID-19. We have to share them. Maybe we feel a little bit like the TB people have been feeling, where HIV pushes out some of the TB labs that need to be done, or probably a million other diseases that are pushed around because of HIV, the need for HIV labs also. I know that there are a lot of smart people working on this, but we do have limited lab capacity, and we have an emergency right now. So what can we do in that case? Well, we can really double down on trying to get people to not skip any ART, to stay on their drugs so we don't see an increase in drug-resistant ART. We can still line up to get people their viral loads. It just may be a little slower than we're used to. And then, you know, we do have to look at the expansion of lab capacity, because COVID-19 is not the last infectious disease that's going to need laboratory work. You know, there's going to be many more. It wasn't the first, it's not the last. But it has highlighted for us with such a serious widespread epidemic that we are still have insufficient lab capacity in most places. And we need to work on that.
Thank you.
Go ahead.
So, sorry, Doris, I wanted to add something. So I was trying to come in before you come in so that I can go ahead with the moderator. So sorry, Hally, for interrupting you. I wanted to actually add that part of the reason why we are not able to answer this question very clearly is because we haven't done capacity assessment for lab, even PCRs across many of the countries. Recently, in a meeting we had with Africa CDC, we were discussing how clear we are on ICU bed capacity. You know, there was a full assessment. Yes. We know where the beds are, which country has how many ventilators, but no one has actually done a capacity assessment on labs, you know, in terms of capacity of tests, PCR, for example, effective PCR capacity, because, you know, you may have the machine there, but it's not in use. So this is something that needs to be done so that we're able to tell in which countries then are we under capacity and what do we need to do. So that's the first point. The second point is it also reflects on the need for holistic health system investment rather than HIV investment. So, because if you now have holistic investment, then you're actually looking at the needs beyond HIV. You're looking at the needs of the entire population and also aiming to make your health system resilient. And resilience is around the health system being able to take the shocks of an epidemic or a pandemic like this one. So it brings back to the lens the need to continue with our commitments on UHC towards building a resilient and strong and equitable health system and not verticalizing it necessarily. Verticalization is important when you have a challenge, and then after that, you horizontalize, if there was ever a question like that, and start to integrate back to the health system. So those are the two things I wanted to highlight after Hally's comments here.
Okay, I think we can take maybe just a couple more, and for those questions we'll not be able to answer, we promise that we will certainly answer them. This is from Collins, Chris Collins. What modifications could be made to the PEPFAR and Global Fund policy, the way they probably provide funding and programming to support more broader health delivery beyond, I suppose, HIV, you know, malaria and TB? You know, are there any changes that would need to be done? Gitahi, this feels like more your question to start with. Yeah. Okay.
No, I actually, as you're asking that question, as I read it here, I remember the time when I was in Ethiopia and I was touring, I was going on a field visit to the Minister of Health then, who then left the ministry at some point. And he told me the struggles around embedding health systems into vertical programs. And that actually, the more you advocate for health systems in vertical programs, the more you verticalize health systems themselves. He gave me an example, for example, of vaccination, where, and I'm not picking on Gavi here, but just giving an example, he said, we pushed Gavi to invest in health systems. And I've said, yes, exactly. We are going to give you money as long as the money is going to put up fridges for vaccines. Now, that's further verticalizing the health system. So the question that we really need to ask is, how do we shift from just, you know, the fact that we know we need to take care of vertical programs like HIV, TB, and, you know, vaccination, but how do we also start to embed in our policies that for us to do better delivery on these programs, we need a holistic health system. You know, if you have very good, for example, ARV programs, but you have no nurses, you have no community health workers, you know, you can't deliver, because even if you put them in the store, they cannot walk to the patient. You need actually a holistic community health system to do what we are talking about, the differentiated community delivery model. If you don't have a holistic health system, community health system, you can't do the differentiated community delivery model. So we need to see this more holistically, and we need to probably look at the policies and see that some of these policies are also based on, I must say, they're based on our M&E frameworks. They're based on our reporting structures. So if the board of Global Fund wants particular M&E results or outputs that say how many people, you know, the 90, 90, 90 or 95, 95, 95, and that is it, then it means that the programs have to focus on that. You cannot put money because the board wants this M&E infrastructure that's based on these specific outputs. But you know, now there needs to be a layered delivery mechanism that actually you need to build this for you to build this. I think the fear has always been that the health system is a factor of the national government, and therefore you may have varied results depending on the country you are in. So it is not only a Global Fund paper conversation, it is actually a global health national conversation as well. So it's a bit complicated, but we are pushing for this. Even for COVID, as I close, I know we are almost running out of time. We've seen now the demand for COVID vaccine, COVID therapeutics, COVID diagnostics. And then lately we are like, oh, but what about the health system? Oh, okay, we'll add something on the health system accelerator. So it always comes as a second thought rather than the first thought to be able to deliver on all the objectives we want to deliver to. Thank you.
Yeah, time flies, and I must say I have thoroughly enjoyed this conversation. We should have gone, I think we gave it too little time. So mine is to say, before I say thank you to the panelists, I want to just ask them, you know, just parting thoughts. The questions that are that we've not been able to answer, I'll just ask them to, we'll definitely get to them, to those questions. But maybe final thoughts. Let's start with Hally. Your final thoughts, 30 seconds, and then Gitahi, and then we'll close.
Just that COVID-19 has amplified all of our challenges, all of our opportunities, all of our successes. We from the HIV world, we see it amplified for COVID-19. Things that have been working in the HIV world, a lot of them we've been able to protect, to gazette, to protect. Things that have continued to be challenges actually are even bigger challenges in COVID-19. But we have so many opportunities. We have so many creative strategies that have been deployed. We need to continue to build on them. And frankly, as countries start to open up again, we should not abandon them. I think that would be what I would request, to reconsider whether expansion of MMD or expansion of community-based ART should really be ended because COVID-19 is under control in a country. No, these things provide opportunities for us to really to get to our 95, 95, 95, and we should not abandon them.
Thank you. Thank you so much, Hally. Gitahi, your last thoughts?
Yeah, last thoughts. The first thing is an answer to a question I've seen around who is going to be financing the lab capacity assessment. We don't know. It's something we know we want to do, and we'll need to work with partners to finance it. So the answer to that question is no one for now, but it's something we need to do. My first remarks are the following. We have said consistently, especially, you know, and I keep saying I'm a health system person, we've said there can be no universal health coverage without comprehensive HIV care. I want to talk to all the HIV advocates here and say, there can be no comprehensive HIV care without universal health coverage. That's all I'll say. Thank you.
Wow. Okay. Wow. Short and sweet. But I just want to thank so much Dr. Githinji Gitahi from AMREF Health Africa, and also Ms. Hally Mahler from FHI 360 for really having this really exciting discussion and answering a lot of our questions. We really want to thank you, and obviously thank Africa CDC and FHI 360. Thank you, everyone, and do have a good rest of the day.
Thank you very much for having me. Thank you.